Arthroscopy, knee, surgical, osteochondral autograft, S, e.g., meniscectomy, includes harvesting of the autograft S. Osteochondral allograft, e.g., meniscectomy. An osteochondral graft is a bone/cartilage transplant that treats defects of the knee from disabling cartilage injury or disease, such as osteochondritis dissecans. Arthroscopic osteochondral grafting using the meniscectomy technique is described here. Multiple cylindrical grafts are placed in corresponding size cylindrical holes made in the recipient area instead of using one larger bone plug. Portals for inserting the instruments are chosen to ensure perpendicular access to the recipient site. Detached cartilage is excised, the margins squared off, and the subchondral bone is abraded to healthy, bleeding tissue. The number and size of grafts needed is determined. In 29866, a tubular chisel is used to harvest cylindrical osteochondral grafts down to the desired level, perpendicular to the cartilage surface, from the patient. Grafts are harvested from the non-weight-bearing patellofemoral area, medial or lateral femoral trochlear rim, or the intercondylar notch periphery. The grafts are ejected from the chisel. A guide tube is put in place and the recipient hole is drilled to the desired depth with a graduated bit, replaced with a tapered dilator, and the graft is inserted and tamped into place. This is repeated until all grafts have been placed. Report 29867 when fresh donor tissue from a tissue bank is used instead of harvested from the patient. Arthroscopy, knee, surgical, meniscal transplantation, includes arthrotomy for meniscal insertion, medial or lateral. A previously removed meniscus, the fibrocartilaginous support of the knee joint, is replaced with a cadaver donor meniscus, medial or lateral. Imaging is done to size match the graft to the recipient knee. The arthroscope and a tibial guide are placed through portal holes. The remaining native meniscal cartilage is removed, including resectioning the native horns. Pins are placed at posterior and anterior horn locations, suture tunnels are drilled over the pins, and sutures are passed. The anterior portal is widened, and both the anterior and posterior sutures are brought out together. The graft is brought in through the widened incision, or a necessary arthrotomy, and sutures are placed through each horn of the implant. The posterior and anterior horn sutures are drawn out through the tibial tunnel and secured to the tibial bone. Meniscal repair techniques are used to suture the graft securely to the capsule, placing knots directly over the capsule. Routine closure is performed. Other techniques may employ separate bone plugs attached to the horns to insert the graft, or a common bone attached to both horns on the graft inserted into a receiving slot in the tibia. Arthroscopy, knee, diagnostic, with or without synovial biopsy. The physician performs a diagnostic arthroscopy of the knee. Portal incisions of 1 cm in length are made on either side of the patellar tendon for arthroscopic access into the knee joint. With the use of the arthroscope and a probe, each compartment of the knee is examined for pathology. This includes examination of the patellar articular surface, medial and lateral meniscus, cruciate ligaments, and joint surfaces. Additional portal incisions may be made to better access some compartments. If there is suspicion of a primary disease of the synovium, a biopsy is performed. A temporary drain may be applied. Incisions are closed with sutures and strips. Arthroscopy, knee, surgical, for infection, lavage, and drainage. Lavage is accomplished with a minimum of 4 liters of a physiologic solution. The irrigation solution is directed into each compartment while visualizing through the arthroscope. Lavage is continued until the outflow is clear. A motorized suction cutter is used to remove encrusted fluid, exudate, and any fibrinous clots. Drains are placed as needed and incisions are closed with sutures and strips. The drains are removed after 48 to 78 hours. Arthroscopy, knee, surgical, with lateral release. The physician performs a knee arthroscopy with lateral release. Lateral retinacular release is done when too much lateral tension on the patella from tightness of the lateral retinaculum causes patellar misalignment, not allowing correct movement. This can be associated with articular cartilage lesions and idiopathic chondromalacia. The physician makes 1 cm long portal incisions on either side of the patellar tendon to arthroscopically access the knee joint. The instruments are inserted and the knee is assessed. The release is done at the end of the arthroscopy. The tight lateral ligaments, including the lateral patellofemoral and the lateral patellotibial ligament, are released, detaching the patella from the soft tissue structures, including the lateral retinaculum, muscle fibers, and joint capsule. Arthroscopy, knee, surgical, for removal of loose body or foreign body, e.g., osteochondritis dissecans fragmentation, chondral fragmentation. A thorough exam is made of each compartment in the knee. Additional portal incisions may be made to gain better access to the knee compartments. Any loose bodies, fragments of cartilage or bone, encountered are removed through the portal incisions. Small loose bodies can be suctioned or irrigated from the joint. Larger loose bodies are grasped by a clamp and removed. Very large loose bodies may require enlargement of a portal or division with an arthroscopic scissor before removal. A temporary drain may be applied and incisions are closed with sutures and strips. Arthroscopy, knee, surgical, synovectomy, limited, e.g., plica or shelf resection. Synovectomy, major, 2 or more compartments, e.g., medial or lateral. Proliferative, diseased synovium is removed with a motorized, suction, cutting resector. If the plica located along the medial side of the patella is inflamed, it may require removal. Removal is accomplished by dividing and excising the plica. The synovectomy is limited. Indiana 29875. For a more extensive synovectomy, 29876, up to 6 portal incisions may be made to access all of the involved compartments of the knee. A temporary drain may be applied and incisions are closed with sutures and strips. Arthroscopy, knee, surgical, debridement/shaving of articular cartilage, chondroplasty. Lesions in the articular cartilage are identified by the arthroscope and the use of a probe. Additional portal incisions may be made to provide better access to the cartilage lesions. Debridement of the unstable hyaline cartilage or partially fragmented cartilage is accomplished with a motorized suction cutter. This smooths the roughened or damaged cartilage. Any loose bodies are removed. After debridement, the joint is flushed. A temporary drain may be applied, and incisions are closed with sutures and strips. Arthroscopy, knee, surgical, abrasion arthroplasty, includes chondroplasty where necessary, or multiple drilling or microfracture. Lesions of the articular cartilage are identified by the arthroscope and the use of a probe. Additional portal incisions may be made to provide better access to the lesions. Debridement of the unstable or fragmented cartilage is accomplished with a motorized suction cutter. The cartilage is smoothed down to the layer of subchondral bone, which promotes bleeding and regeneration of cartilage. Any loose bodies are removed. The physician may also drill holes into the subchondral bone or create tiny fractures, microfractures, to further promote cartilage regeneration. The joint is flushed. A temporary drain may be applied. Incisions are closed with sutures and stri strips. Arthroscopy Knee Surgical, with meniscectomy, including any meniscal shaving, including debridement/shaving of articular cartilage, chondroplasty, same or separate compartment, S, when performed, medial and lateral. Medial or lateral. Once the meniscal tear is identified, additional portal incisions may be made to provide easier access to the area. There may be a tear on both the medial and lateral meniscus or on only the medial or the lateral meniscus. The procedure is the same for medial or lateral meniscal tears. Angled scissors, a motorized cutter, or punch forceps remove torn fragments. The remaining intact meniscus is trimmed and contoured. A temporary drain may be applied and the incisions closed with sutures and stri strips. Arthroscopy Knee Surgical, with meniscus repair, medial or lateral. Medial and lateral. The meniscal tear, S, is identified through the arthroscope. There may be a tear on only the medial or the lateral meniscus or both may be torn. Depending on the site of the tear, other portal incisions may be made to gain better access. Angled scissors, motorized cutters, and punch forceps are used to debride the tear margins and break the surface of the adjacent synovium in preparation for repair. A 3 cm to 4 cm incision is made along the medial or lateral joint line, depending on which meniscus is torn. A cannula passes sutures through the meniscal tear and out through the joint line incision. A temporary drain may be applied. Subcutaneous layers are sutured and skin closure is with stri strips. Typically, a hinged knee brace is applied after surgery. Arthroscopy Knee Surgical, with lysis of adhesions with or without manipulation. A blunt trocar, a knife, scissors, or a mechanical shaver may remove any adhesions limiting range of knee motion. If a manipulation is performed, the physician will remove the arthroscope and apply gradual, progressive pressure to bend or straighten the knee. Manipulation helps the knee regain range of motion. A drain may be applied. Incisions are closed with sutures and stri strips. Arthroscopy Knee Surgical, drilling for osteochondritis dissecans with bone grafting, with or without internal fixation, including debridement of base of lesion. The defect is visualized through the arthroscope. Any loose bodies are removed with grasping instruments. A motorized suction cutter is used to debride the disrupted hyaline cartilage. Drill holes 2 cm in depth are made into the lesion, penetrating the vascular bone at the base of the defect. The donor harvests bone from the patient's hip, rib, or skull and closes the surgically created donor site. The bone is sized to fit the defect. The physician determines if a screw is needed for internal fixation. If so, a screw is placed. A temporary drain may be applied. The incisions are closed with sutures and stri strips. Arthroscopy Knee Surgical, drilling for intact osteochondritis dissecans lesion. With internal fixation. The defect is visualized through the arthroscope. A motorized suction cutter is used to debride the disrupted hyaline cartilage. Drill holes 2 cm in depth are made into the lesion in order to penetrate the vascular bone at the base of the defect. This promotes bleeding and subsequent healing of the lesion. The incisions are closed with sutures and stri strips. A temporary drain may be applied.